Hi, good evening, everyone. Thanks for joining us. I'm JD DeTola from NYU, and I want to welcome you to our nerve injury webinar, where we have a very exciting lineup of faculty presenting tonight. The first talk is going to be by Dr. Ali Azad, who is an assistant professor of orthopedic surgery with me at NYU. He's going to be talking to us about the indications, techniques, and outcomes of primary nerve repair.
Perfect. Thank you so much, JD. As Dr. DeTola said, I'll be talking about direct nerve repair, and some of my counterparts will be talking about some of the options when that's not possible. I have absolutely no disclosures. So let's get started. So, step one is defining what a direct nerve repair is, and that's defined as an end-to-end coaptation of separated nerve ends. And this can be further subclassified based on timing as well as technique. So the timing isn't a agreed upon point, but generally most people say a primary direct nerve repair is prior to 7 days and a secondary direct nerve repair is after 7 days. And then the technique in which you repair the nerve, whether it's epidural, whether you're repairing the fascicles together, or whether you're grouping the fascicles and repairing those together, those aspects aren't going to be a very involved part of this talk, but just be aware that they exist. The best indication to perform a direct nerve repair is when the two ends of the injured nerve can be reapproximated with no tension in a well-vascularized bed of surrounding soft tissue. That's critically important, the no tension and well-vascularized bed of soft tissue. This is often seen in acute sharp transections, but factors such as timing of injury, mechanism of injury, associated injuries, and patient factors all need to be considered, as some of these may preclude a direct nerve repair. Some examples include a blast injury, traction or crush injuries, and these can result in segmental injuries that will create too much tension if you try to coap the two nerve ends together. Similarly, a contaminated wound, any setting of infection, or if there's a soft tissue defect that needs reconstructed, these scenarios as well may preclude a direct nerve repair, and a delay may be more appropriate. Any in-hospital environment will result in a kind of essentially a lack of nerve regeneration. So your work will be for nothing. So lastly, before we jump into the technical aspects of a nerve repair, we should briefly touch on why we strive for a direct nerve repair and take the time to consider each of these factors. The primary reason is that direct nerve repair is assumed to give the best result compared to other nerve repair methods. It's kind of intuitive and it makes sense as it more closely restores the anatomy. However, it's not surprising that there's really no randomized control trial directly comparing alternatives or alternative techniques, because when a primary repair seems possible, there's really no great justification to do any of the other repairs. That being said, there are retrospective studies that have shown early direct nerve repair has a favorable result compared to other methods, but these are retrospective and they're comparative. They're not really head-to-head. So keep that in mind as well. Now I kind of want to jump into the technical factors of doing a direct nerve repair. We've defined what a direct nerve repair is, as well as the ideal setting. So next, how do you achieve a good nerve repair? When coapting the two nerve ends together, too much tension can result in ischemia at the nerve ends and scarring at the repair site. There are a couple studies that have shown this. One of the most notable is by Clark et al. And this is a rat model showing that elongation of the nerve by 15% resulted in an 80% reduction in blood flow with minimal recovery at 30 minutes. So that's valuable information to know when you want to put a nerve together, but how do you avoid that intraoperatively? How do you assess that? Unfortunately, there's no precise way, there's no accurate way to determine this, but some authors have stated that two 9-0 sutures at 180 degrees apart and being unable to approximate the nerve ends means there's too much tension. The most scientific approach was taken by a study by Smetana, who evaluated various suture sizes and material and figured out what suture would fail at a tension or a strain rather of 5 to 8% to avoid neural ischemia. And they found that a single 9-0 nylon provided the most predictable failure at this strain level, and the mode of failure was suture breakage. So If you can bring the two nerve ends together with a 9-0 nylon, you can rest assured that likely you're not applying too much tension. So now that we know why tension is bad, what causes tension? So the number one factor that causes tension really is all rooted in time. After a nerve laceration, due to the connective tissue composition, there's immediate retraction. And with time, you lose the elasticity in the nerve ends. At the same time as that is happening, there's also scarring of the nerve adjacent to the tissue, as well as neuroma formation. And neuroma formation can happen as early as 7 days. So you have to, as time goes on, you have to deal with a retracted nerve that's lost elasticity, the scar formation from the adjacent soft tissue, and neuroma formation at both nerve ends that you have to cut out. So each of these things results in a larger gap and increased tension. So how do you avoid tension? The best way to avoid tension is to repair early. Early intervention is key. Other methods include nerve mobilization. If you're dealing with an ulnar nerve laceration, you can always transpose it anteriorly, which will give you several centimeters of increased relative length. And then lastly, another technique is to broadly distribute the tension with placement of a nerve conduit over the repair site with sutures running through the outer edge of the nerve conduit into the epineureum. And this decreases the tension right at that repair site, which is where most of the strain and tension is felt when you do this repair. The issue is that in most cases, when the nerve retracts, most of the tension, as opposed to being distributed across the entire nerve, is kind of focused at that repair site. So some people really believe in these conduits as a tension modifier. And then lastly, extremity position. So if you have to put the extremity in an odd position that's going to have detrimental aspects to the patient's function down the line, result in stiffness, that's too much tension. So, if you have to put the extremity in this position to avoid tension, it's better left alone. So on to another technical factor, nerve resection. How much nerve do we resect? Without adequate resection of injured or neuromatous tissue, the intraneural scar will actually block the regenerative axons as well as the migrating Schwann cells. And this results in inhibition of revascularization, inhibition of nerve regeneration, and a less than optimal outcome. So as with any traumatic injury, our goal is to debride the tissue until we're outside the zone of injury. And in this case, until you see healthy fascicles. So this should be done at 1 to 2 millimeter resections from each nerve edge until you, sorry, the lights turned off in this room, but hopefully you can still see me, so I'll continue. So you take 1 to 2 millimeter segments from each nerve end, and then there's several things you're going to look out for. You're going to look out for bulging fascicles beyond the epineurial edge. That's a good sign. Punctate fascicular bleeding, another good sign. And if the nerve end feels supple, as opposed to firm and fibrous. These aren't the greatest and most effective means, but they're really you're all you have intraoperatively. So another thing to evaluate that some have written on is evaluating the patient's heart rate. So with the proper amount of anesthesia, if you decrease the amount of anesthesia, there's a nociceptive response when trimming healthy nerve ends, and you'll see an increase in the heart rate. I haven't used that method. I don't know how effective it is. And then lastly, another method written about but seldom used is using a pathologist to evaluate the nerve sections until at least 75% of the nerve has normal fascicular architecture. Two issues with this. Most of these surgeries are done in an outpatient center where they're not capable of doing that. And then in most institutions, you don't have a pathologist readily available. So this has made that approach very, very limited. On to the next technical factor to consider, which is alignment. And this refers to the matching of the fascicular patterns of the proximal and distal stump. Although we know that the nerve tissue grows towards nerve tissue, which is defined as neurotropism, end organ specificity is less understood. So what that means is we don't necessarily know if motor fascicles grow towards motor fascicles and if sensory fascicles grow towards sensory fascicles. So the best thing to do is visually inspect the pattern and try to match it. In addition to inspecting the fascicular pattern, you can also look at the surface as well as the deep blood vessels and try to match those up around the perimeter of the nerve. And then we briefly touched on this, but of the three different end-to-end repairs, epineurial, group fascicular, as well as fascicular, group fascicular and fascicular repairs intuitively allow for better alignment, but the lack of evidence supporting a clear superiority in outcome, as well as increased difficulty and the risk of neural scarring when you're doing those dissections, have made these really not the preferred technique. For a vast majority of surgeons, the preferred technique is an epineurial repair. And then lastly, hand in hand with alignment is approximation. So when bringing the nerve ends together, you need to avoid over tightening. This can result in bunching of the fascicles as well as fascicular escape, which can result in neural scarring and prevention of growth towards the distal target. The nerve ends should really be barely touching, or even a slight gap is preferred to bunching. So now that we've talked about how to bring together, so now that we have brought the healthy trim nerve ends together, we need to figure out what is the best means of fixation. In orthopedics, and we always talk about fixation. In a nerve, it's no different. You have to approximate the nerve, but you also have to hold it there while it regenerates. So the two most widely used options include microsuture as well as fibrin glue. Microsuture, either in 8.0 or 9.0, is really the gold standard that we use. And this study by Dr. Strauch kind of looked at, similar to our flexor tendons, what provides a superior repair. And not surprisingly, the greater number of sutures, the larger caliber, and the greater purchase length. But most notably, the number of sutures was provided the stronger repair. But a lot have been transitioning to use of fibrin glue as an adjunct or solely for their nerve repairs. And the reason is that they found that the nylon sutures can cause a granulomatous inflammation. And some of the animal histologic studies have shown increased axonal regeneration, fiber alignment, and nerve recovery with the use of fibrin glue. The only issue is that what is the strength? Now, the literature that's available is pretty there's a lot of heterogeneity to the literature that's out there, in that some show that there is no difference in the stiffness or peak load to failure, but others show there's a significant difference. So what a lot of people have opted for is to maybe use less sutures and use fibrin glue as an adjunct to try to decrease the amount of inflammation. And then lastly, the age-old question of loops versus microscope. So the initial study that looked at this found no difference. This was a study by Bernstein et al. It found no difference when comparing the two as far as clinical outcomes. But this original study only compared 4 to 6x magnification loops compared to a microscope. They also did a phase 2 of that study where they asked people what they use, asked surgeons what they use, and about half the surgeons used loops, but 78% of those surgeons used 2.5 and 3.5 loops. So then they did a third part of that study where they did anatomical repairs and evaluated them. And they actually found that 60% of the repairs done with a microscope were excellent, whereas only 29% with loops were found to be excellent. And then lastly, Thomas et al. Redid this study using 2.5 and 3.5 loops, and they similarly found no difference in clinical outcomes. Now, part of the problem with this is power, but you can take these studies for what they are. Many people don't have the capability of using a microscope readily in their institution, but I think a 2.5 or 3.5 size loop is very reasonable to do a digital nerve repair as well as more proximal repairs. And then lastly, now that we've touched on all the technical aspects of a direct nerve repair, we should have a little understanding of the outcomes. So this is most important whenever you counsel a patient. They need to know that after their nerve is lacerated, there's a very low chance that it'll get back to normal, and they need to understand that very clearly. The goal for them is sensibility, is protective sensibility. And in a number of studies that have retrospectively looked back at their own cohorts, they found that return of less than 6 millimeter of 2-point discrimination was only occurred in about 15 to 30% of patients, and 30% regained 6 to 10 millimeters. So that's about 50% of patients record what's considered a satisfactory return of sensation with digital nerve injuries. And then moving on to mixed motor nerves. This is an entirely different beast, but many people have looked at their own studies as well. And they've actually found that 40% of patients had satisfactory sensory recovery. So again, that's a protective sensibility plus a 2-point discrimination of less than 10 millimeters, which seems pretty fantastic. And then 50% received or obtained satisfactory motor recovery, which they count as an M4 or M5, based on the Dellon-McKinnon classification. Now, in all of these factors, when you look back and you say, what was the number one, number two cause of worse outcomes? It's age and it's injury location. So it makes sense that the more proximal injury locations will have a later and worse recovery. And it makes sense that older patients, like in any other study, by and large, have worse outcomes than young patients. And the delineation in these was really less than 16 years old compared to greater than 40 years old. So there's no there's no real set cutoff, but really you should know younger does better and earlier does better. And then interestingly, if you're comparing ulnar to median nerve, the median nerve was actually found to have far greater satisfactory restoration of motor and sensory recovery. So in summary, peripheral nerve injuries of the upper extremity require an understanding of multiple factors. These include the patient factors, injury factors, and repair techniques. Expeditious operative exploration and direct end-to-end repair is the goal when amenable. And the when amenable part is the most important. You need to avoid tension at all costs. I think doing a simple 9-0 nylon test is what I use, and I think the best thing we have right now. And you need to be honest with yourself that, you know, if that doesn't work, then you need an autograft or an allograft in certain scenarios. And then lastly, I think it's good to consider a combination of suture and glue to decrease the inflammation and increase the strength of the repair. And also, most importantly, guiding patient expectations is one of the most important things we do as physicians, and really knowing the literature and guiding their expectations. I think doing that alone will result in a happier patient. Thank you guys all very much. I apologize for going over, but honored to be part of this CME.
Awesome. Thanks, Ali. That was a great talk. It's my pleasure to introduce our first guest speaker, Dr. Robert Strauch. Dr. Strauch is a professor of orthopedic surgery at Columbia University Medical Center, and he will be speaking to us about the different treatment options for managing nerve defects.
Hi, thanks for inviting me. Yeah, I'm going to talk about how to bridge the nerve gap, nerve tubes, allograft, and autograft. So, as has just been nicely pointed out, when a nerve is cut, the ends retract, and sometimes after mobilizing the nerve ends and resecting back to healthy tissue, you can't get it together without excessive tension. The space between the nerve ends is the nerve gap. Years ago, Hanno Malaysia and others popularized the concept that repairing a nerve under tension is bad. Therefore, the nerve gap can be bridged either by nerve grafting or using a hollow nerve conduit to get a tension-free repair. But please, at least try to get the nerve back together primarily, and this can be done by extending the incision, gently dissecting out the nerve and mobilizing it, and consider mildly flexing the joints to take the tension off. You see, some tension across the repair site is actually not that bad. Rod Hentz, in a 1993 primate monkey study, that's hard to do nowadays, using an ulnar nerve gap model, found that repairs under tension did better than autografts. In this study, tension was determined by placing an 8-0 nylon across a nerve gap so that it wouldn't pull out in 30 degrees of wrist flexion, but would pull out when the wrist was extended to neutral. This was his study in the Journal of Hand Surgery, and Hentz suggested that for modest defects of even up to 3 to 4 centimeters in humans, which is a lot, it was probably better to accept some tension in the repair than to do an interposition nerve graft. Sunderland and McKinnon also found that rat sciatic nerves did better with the repair under modest tension, which corresponded to a nerve gap of about 9 to 10 millimeters. Now, they did not mobilize the nerve in this study, but they found that if they dissected out the nerve a little bit more, the tension actually was markedly diminished and the nerve ends easily came together. And there are many other studies showing that nerve grafting is not equal to primary repair. So please try to get the nerve ends together, and you'll be surprised by how much the tension is alleviated doing some more nerve dissection. I'll even temporarily put a 7/0 nylon suture in between the nerve ends, let it stress relax for a few minutes, and initially it'll blanch like you're closing a tight skin wound, but then it pinks up. And so, and then I'll take that suture out, of course. And it's also okay to flex the joints a little bit. You don't want to flex it 90 degrees like we saw in Ali's talk, but you can flex it 20 degrees. It's not too bad. You can stretch that out after surgery. So primary repairs do better than nerve grafts of any kind. When evaluating outcomes, it's very important to see what is considered clinical success or meaningful recovery, and it varies between studies, so you really need to see what they're talking about. In general, a sensory recovery of S3 plus can be up to 15 millimeters of 2-point discrimination, which is not that great. And M4 is not bad, but M3 isn't so great either. And some studies use M3 as meaningful recovery. In general, ulnar nerves do worse than median or radial nerves, as has been mentioned. Younger patients do better than older patients. Females actually seem to do better than males in some studies. Primary repairs do better than grafts, and the bigger the gap and the bigger the nerve graft, the worse the outcome usually. A large study pooling the results of 3 nerve repair articles from Louisiana State University was done in 2009. For primary repairs, they actually had pretty good results, with median and radial nerves at 90% good results. Ulnar nerves were about 70%. But for nerve grafts, the median and radial nerves were only 70% to 80% good, and the ulnar nerves were only 50 to 60% good. Now, the options for overcoming the nerve gap, if you really can't get it together, involve either hollow nerve tubes or grafts. The tubes can either be autogenous veins or other absorbable type tubes, while the nerve graft options include autograft or processed nerve allograft. Let's start with tubes, aka conduits. Technically speaking, a nerve graft is also a conduit, just a solid one, so the terminology is a bit confusing. But when we say conduits, we're usually referring to hollow tubes. The use of nerve tubes dates back to the 1800s when a guy named Themistocles Gluck used decalcified hollow bone tubes to join nerves together. The upper length limit of the conduits is generally considered to be 3 centimeters, although outcomes are worse the longer the tube. And conduits are mostly used for digital nerve gaps, which are purely sensory and not used for motor or mixed nerve, although there are some anecdotal success stories for median and ulnar nerve repair using conduits. David Chu and Beres Strouch, who I actually know very well, in 1990 reported encouraging results using vein grafts for what they term non-critical sensory nerve gaps under 3 centimeters in length. In this study, primary repair and autografts did do better than the vein grafts, but they did reasonably well with the vein grafts with less donor site morbidity. The vein used should be twice the diameter of the nerve and 50% longer than the gap. The vein should be reversed, and some people turn the vein inside out. Vein collapse would seem to be likely, but apparently it does not occur owing to hematoma forming within the tube. In a 2011 prospective randomized study comparing vein grafts to polyglycolic acid tubes, excellent 2-point discrimination was achieved in both groups, with less complication using veins, since the PGA grafts would sometimes spit out. In 2000, Weber et al. Conducted a randomized prospective study of PGA conduits for digital nerve reconstruction and actually found better results with conduit repair for nerve gaps of 4 millimeters or less compared to both autograft and primary nerve repair. Now, there are some troubles with that study people have pointed out over the years. The nerve tube technique for collagen tubes is to choose a conduit slightly larger than the nerve diameter. You have to hydrate it first, and it expands, so don't trim it until it's hydrated, and then trim it at least 5 millimeters longer than the gap. You want to pull the nerve into the tube for a distance at least equal to the diameter of the nerve using outside-in sutures. I'll usually put 2 sutures on either end, but the technique guide I read the other day actually says to use 3. Some people squirt saline inside the tube. The physiology of nerve tubes is that within hours, the lumen fills with neurotrophic and inflammatory cells. In days, a fibrin matrix forms. In weeks, Schwann cells and fibroblasts migrate along the matrix, and in months, the axons regenerate from the proximal nerve end across the fibrin matrix. Now let's move on to nerve grafts. So autograft is still the gold standard, but of course, donor site morbidity is the downside. For larger nerves, several cables can be used, and the repair can be done with sutures and/or glue as desired. Some surgeons wrap all their nerve repairs with wraps, but there's not much evidence for this at the moment. Nerve allografts are also called processed nerve allograft, or PNA, and the only available one on the market is made by Axogen at the moment. As we will see, the basic science and clinical studies provide variable results when compared to autograft. However, there's no donor site morbidity with the PNAs. Let's start with nerve autograft, the gold standard. Sural nerve harvest can produce donor site numbness. It does produce donor site numbness and occasionally a painful neuroma. The medial antebrachiocutaneous nerve can also cause a painful neuroma. The distal posterior interosseous nerve has minimal morbidity to harvest and no neuroma formation, but has a low axon count. The longest autografts that usually work are less than 6 centimeters in length, but there have been reported successes up to 20 centimeters in length, and most of the nerve graft actually survives. There's a question whether or not the nerve graft polarity should be reversed, end for end. The thinking is that if you don't reverse it, some branches of the nerve can bleed off valuable axons and prevent them from reaching the other side. Well, it turns out that it probably doesn't matter. Scott Levin did a systematic review of this topic nicely and found that you do not need to reverse the graft. Now, processed nerve allograft is a product harvested from human donors. It's treated with gamma rays and processed while preserving the nerve architecture. There are no cells. It requires refrigeration and can last 6 months before it must be discarded. It's thawed for about 10 minutes and then must be used or discarded after 12 hours. And they come in various diameters and lengths up to 7 centimeters. Here are some of the positive basic science studies. In 2009, in a rat model, Whitlock found that Axogen was better than nerve conduit, but not better than nerve graft. In 2019, Peter Tang et al., in a rat model study published in JBJS, found Axogen to be equal to cable nerve grafting and equal to reversed autograft. Now for some of the negative basic science studies. In 2011, Moore et al. Found that Axogen was superior to silicone nerve conduits, but worse than autografts. In 2012, Giusti et al. From the Mayo Clinic in a JBJS rat study found that autograft gave better motor recovery than Axogen or the conduit. Now for some positive clinical Axogen studies. A 2009 study by Jonathan Isaacs found encouraging results for 4 to 5 millimeter diameter allografts. In 2012, Cho et al. Found S3 or M4 recovery in 86% of Axogen procedures with grafts up to 5 centimeters long, which is pretty good. However, in this study, there were 2 nerve repairs that had absolutely no functional recovery at all. A 2017 study by Rinker found favorable results for Axogen compared to historical results of nerve autograft repair. Safa et al. In 2019 found meaningful motor recovery in 73% of patients following mixed and motor nerve repairs using Axogen, also pretty good. In 2020, Leversage et al. In a multi-center study found better results using Axogen compared to conduits, collagen conduits in digital nerve reconstruction. Now for some of the negative clinical studies. Leckenby et al. Looked at 207 Axogen grafts and found that only 36% achieved M3 scores or better. The longer and the wider the graft, the worse the results. A 2018 report in the European Journal of Hand Surgery of 3 patients found poor results owing to reabsorption of the graft. McKinnon in 2019 noted that an issue that's seen with conduits and allografts was that occasionally you wouldn't get any regeneration at all, something she said she rarely, if ever, saw with an autograft. In the most recent version of Green's Hand Surgery in the brachial plexus chapter written by the Mayo Clinic group, they strongly recommend not using Axogen conduits or PNAs for instead of autografts, and also not using conduits. Meanwhile, a survey of hand surgeons from 2018 found that nearly 70% of hand surgeons used Axogen, and in a clinical scenario of a digital nerve gap, the majority would use Oxygen as opposed to conduit or Autograft. In conclusion, try a little bit harder to get a primary repair if possible, since that's better than any graft. A sharp recent major nerve transection should really be able to come together without a graft. When you can't get the nerve together, then tubes or allograft are okay for digital nerves. For motor or mixed nerves, such as the median, ulnar, or radial nerves, Autograft is still considered the gold standard, but Oxygen is catching up. And don't use a hollow tube for major nerve injuries. Thank you very much.
Thank you, Dr. Trash. That was great. Our next guest speaker is Dr. Stephen Lee. He is the chief of the Hand and Upper Extremities Service at the Hospital for Special Surgery and professor of orthopedic surgery at Weill Cornell Medical College. He also serves as the director of research at the HSS Center for Brachial Plexus and Traumatic Nerve Injury. And he's going to be speaking to us about nerve transfers.
Okay, can you hear me?
Yep.
It was strange when I was moving around. You used to see the unmute thing. It wasn't there. So, well, hello, everybody. Thank you for joining us. And thanks, JD, for organizing this. I'm going to talk about nerve transfers, a subject near and dear to my heart. Do a lot of these and a lot of information. So we could be here for like 2-3 days talking about nerve transfers. I'll try to do, just highlights in 15 minutes. So the definition of nerve transfer is the coaptation of a healthy nerve donor to a denervated nerve stump. Very similar to tendon transfers, where you take you have a necessary distal function, and you recover that by sacrificing another function that is either less essential to the patient or it's redundant. Some old terms, neurotization, heterotopic nerve suture, nerve crossing, you might see in literature, but now it's really called nerve transfers. Now an old article, but one that really a lot of people refer to as this article in the Journal of the AOS. Indications would be if the proximal nerve stump is injured or unavailable to reinnervate to the distal nerve stump, as you've heard, by repair or some sort of graft or tube. But even if you have a functioning proximal nerve, but that distance for that nerve is too long, if that graft would be too long, you have to remember that the motor end plates and muscle only last about 12 months and they just fade away. So when you do your nerve repair reconstruction, you have to think it has to grow all the way down. And so if it's just too far away, you might do a nerve transfer where you get active and live axons closer to the target. If you have a broad zone of injury, if that gap is going to be quite large, I know Rob talked about, some people say that large gaps don't work. It's not always the case. Like in plexus, we actually have to use like really long grafts. It can be up to 11 to 15 centimeters, and those can work. But generally, the longer it is, the less successful it is. This is an orange statement I put in there, and that's, as my trainees know, that's usually an answer to frequently asked questions on examinations. The major advantage of the nerve transfer is to shorten the length of nerve regeneration by bringing that donor closer to the target. Super important concept. Contraindications, obviously, if there's something better to do, if it's just too long, even with the nerve transfer, and usually if the person has just arrived to your doorstep too late, from when the injury was. And then if the donor nerve is not strong enough, kind of like if you're going to do a tendon transfer and your donor tendon is too weak, you're not going to use that as well. Now, we use EMGs, and it can be very helpful to know if you have a strong enough donor, but you need a very specific kind. We published this in 2014. And if you look at that bottom, I'll do this little laser situation here. Here we go. Cool. This over here, we use a very specific EMG where you have the needle in the muscle, you ask them to contract. If you get total flatline, that's none. On the other the spectrum is full, like totally normal, screen full of waves. If it's decreased, it's clumps of waves, and basically full and decrease, if you see this in EMG, that'll give you a good donor. Discrete over here, single waves like this. Interestingly, we found that you can't always clinically tell the discretes. They can feel pretty good, but if you see on an EMG, that is not going to be a good donor. We learned that. It's a long story how we came to this this whole project, but so clinical exam doesn't always correlate with an EMG, and the pre-op EMGs can predict the donor. So let's go over some scenarios when to consider nerve transfers. For instance, high nerve injuries or plexus injuries. Those are like, kind of key usual things. So what is a high nerve injury? Well, generally it's thought to be above the elbow. And it depends which nerve it is, and the worst obviously is the ulnar nerve because your motor targets are in the hand. And so you really want to, for me, if somebody comes in with a nerve injury, obviously I want to know, what is it? But the other, next question is when did it occur? Because if it's too late, and you're not going to make any, there's no possible way for nerve recovery, then that's just, that option's gone. You have to think of, secondary options like tendon transfers or fusions or whatnot. So when did it occur? So, and if it's, or a nerve transfer, but so generally above the elbow, and really just, each case is different. It's unique. Remember that you only have about that year, but you really just have to map it out. You have to, I take a ruler out and actually just measure it and think of, how long will it take? So, if it's too high, nerve transfer is one of the options. Let's go through, each of these nerves, for instance. So you have the ulnar nerve, the radial nerve, median nerve. For the ulnar nerve, and I put this down here, and I'm going to go into more detail because this is like one of the classic. I should actually put this in an orange statement because this is a super classic one that's always talked about. It's really common that you might come to this scenario. For high ulnar nerve injury, you see the literature, and there's even for people who have like a very severe cubital tunnel, it's been done. But basically, you're taking the AIN and you're hooking it up to ulnar motor to nerve transfer in the distal forearm. For the radial nerve, this is a controversial topic, doing nerve transfers versus tendon transfers. That's a frequent topic that you see in debates and stuff like that, and the hand society and so forth. For me, I'm generally still doing tendon transfers. I don't want to, they're just so successful. They're just so reliable in my hands. And if you do a nerve transfer for that and it doesn't work, you burn bridges. But if you're going to consider nerve transfer, that'd be the branches of the peroneal teres, the ECRL, branches of the FCR to the PIN. And then the median nerve, as we know, that's, frequently, or the most important thing that you're losing in median nerve injury is actually the sensibility. I always think of Dr. Posner when I say sensibility and not sensation, because that's the proper term. So sensibility, you can take nerve that's coming from the ulnar side, bring it over. You can also take radial, and you can there's also new ones in the forearm and so forth. But median nerve, think about sensibility. And then the super classic ones, they actually were born out of plexus injuries, these nerve transfers. And this ulnar median fascicle, the biceps brachialis, is sometimes called the Oberlin, from Christophe Oberlin. I visited him in Paris. An amazing person and surgeon who's really revolutionized nerve surgery for us. And then there's the triceps axillary that was popularized by Somsak in Thailand. I visited him. I saw him do that operation. It's really cool to visit people and see them do the operation, see them, see their patients, and spend time with them and hear all their thoughts. The spinal accessory to suprascapular nerve, intercostals, those are all like classic ones that we'll just touch on, just the highlights of nerve transfers. For instance, ulnar nerve injury above the elbow, you can consider the AN to ulnar motor transfer. First discussed in China in 1997, and then later in 1999. And then McKinnon also talked about this in 2002. This is a good paper to put in your computer storage of literature. 2009. It's operative nuances, really good technical tips. Taking some pictures from here. But they actually retract, earlier that paper made it sound like it was really awesome. And this transfer isn't super awesome, but it's good. It'll stop people from getting like a wicked claw, which is great because a terrible claw is a terrible problem. You can't open your hand, you get a flexion contracture. It usually stops that, thankfully. Part of the reason is that the axon mismatch, actually, the ulnar motor is 1200 and AAN, so it's highly variable too. Who's ever done this operation, the AAN can be really puny sometimes. Some photos from my partner, Dr. Wolf, and open up Guions. You want to decompress the distal part, dissect the motor branch. You can actually dissect it all the way back or just know the topography. I just use topography. Dr. McKinnon says sometimes eye dissection. It's really knowing the topography. You find the AAN as it goes under the PQ. It's got fat around it. And this operation really occurs in kind of the distal third of the forearm. Quite a big incision, actually. Open up that PQ, expose the AIN, see those branch points. You want to, you might have heard her say donor distal. So you want to dissect it as far distal as you can. That's the donor. And then come up to the ulnar motor recipient. And how do you know where it is? It's really the topography. You find the sensory, actually you find the dorsal branch of the ulnar nerve coming off. And you can see that in this image down here. And then the motor is between the dorsal branch of the ulnar nerve and the radial part, which is actually the sensory to the ring and small fingers. So that group of nerve tissue that's just to the side of the dorsal branch is the motor component. And you'll separate those out, intrafascicular dissection, and then end to end it over here. It looks like this in a schematic. So this is the AN coming into the ulnar motor that you've done. So you want to go donor distal, you want to cut it way on here, but then recipient, you cut way back proximal so that you have no tension, as you've heard, or decrease the tension in that. And so that applies to nerve transfers as well. Here it is. I use, as you heard from Dr. Azad, I agree with that. I use minimal sutures. So I usually use a couple sutures and then glue. If there's some tension there, or not in this kind of scenario, but just as an aside, sometimes you use a conduit type material and then use detention sutures. Anyway, some priming glue and some pearls for this is to release that ulnar motor in Gans canal, find the dorsal branch, and it's the component just adjacent to that. And go into the PQ, donor distal, and this end to side supercharge. That's if you think that you'll get some nerve regeneration expected and you just want to augment that. Radial nerve, the gap's too great, delayed injury, pretty common scenario. And this is a paper that was earlier on, and it really had not great results overall, 5 to 19 for recovery. And I'd have to say that most people have done tendon transfers for this problem don't get 5 out of 10 or 5 out of 19 for. Alternatively, you can use PTDs or L, as I mentioned before, FCR to PIN. And this makes more sense to me if you're going to do it. It's more synergistic, and they had good results. So once again, it's controversial. This is a very standard tendon transfer set that I do instead. And then median nerve, I had mentioned that you can take some of these branches from the non-essential parts of the ulnar nerve and bring them over to the median. Bertelli has talked about using actually distal branch the radial nerve to the sensory. Quickly, some plexus ones in 2 minutes. Spinal accessory to suprascapular nerve, a very common workhorse transfer to get the supraspinatus and infraspinatus to help the shoulder, stabilize the shoulder and help some motion of it. Intercostal nerves, 70% with M3+. Very challenging operation. Tiny nerves. It takes a long time to dissect these out. This over here are 2 intercostals going to go to the axillary, 3 intercostals going to musculaneous. And you can get this kind of result, which is not happening when I hit the video, unfortunately. Let's see here. Let me, okay. Well, if you had that video going, you'd see her elbow bending and her shoulder coming up. I'm not sure if tech support can make that go. No. Yeah. Okay, let's keep going. Oh, there we go. Thank you. Now you see the floppy hand, though. It's very hard to get the hand. She actually did get some hand back 2 years later, and was actually a success story for someone who got it complete when she started out. Going on to a very classic one is the Oberlin transfer, as I mentioned before, first written up in 1994, then 2004. This is one that's frequently in board type questions. It's like the best transfer I think that there is. If you see somebody who can't bend their elbow and they have a hand that works, it's a great transfer. I've done many of these and they usually work. This is what it looks like clinically. And this is a patient who, there it goes. She is bending her elbow. It's that you can see the scar on the medial arm. And here she is. It's her right arm. You can see the contour of her biceps there. It does work. And here she is 3 years post-op. You can see her shoulder and her elbow function. This is the SOMSAC, triceps branch axillary nerve from posterior arm. You can do it from posterior or the axillary approach. And you're basically taking triceps branch, swinging up the axillary nerve in this kind of fashion to get from your deltoid back. This is SOMSAC, 2003, wrote about good results with this, and it does work. So in conclusion, nerve transfers have really revolutionized results of nerve reconstruction. It should really be a part of your armamentarium, your toolbox. And that theme is expendable donor or a redundant donor to distal target. Thanks very much.
Thank you, Dr. Lee. That was a great overview of a pretty broad topic. Our next speaker is Dr. Martin Posner, who just recently completed his 50th year as chief of the hand division at NYU. Dr. Posner will be speaking about opposition tendon transfers and sharing some of his technical pearls. Hey, Dr. Posner, I think you may still be on mute.
How's that?
Perfect.
So the relevancy of my talk is only if some of the wonderful procedures that were just described by some of my colleagues are not effective. Because there's no question that if reinnervation of paralyzed thenar muscles can be achieved by a median nerve repair or reconstruction, the results are better than any opposition transfer. John Napier taught us that through evolution and the use of tools, the human hand developed essentially two types of grip. Precision grip, as example of precision grip of grasping a sphere, and power grip as grasping a cylindrical club. As we know, thumb motions consist of flexion and extension in the coronal plane and abduction and adduction in the sagittal plane. So eliminate using the term radial abduction or palmar abduction. It's abduction, period. And opposition is a combination of flexion, abduction, and pronation. And the most important joint is the CM joint. In astronomy, planets are said to be in opposition when their orbits are 180 degrees. And similarly, in the hand, the thumb is in opposition to a finger when it's abducted and rotated, and also that its pulp is also rotated toward the finger. Sterling Bonnell in 1944 mentioned that opposition is expressed in the distance of the thumb pulp from the base of the middle finger, probably from the metacarpal head or from the MP joint. So the distance is the same regardless of the size of the object. The thumb doesn't change in position. It's the finger that changes in position depending upon the size of the object. If I was giving a talk about principles of tendon transfers, These are the three main topics that I would discuss. And under topic 3, there's 6 different factors in selecting a donor muscle. But for this talk, it's unnecessary to cover all that material, and I'm just going to cover timing of the operation, and with respect to the selection of the donor muscle, force, amplitude, and direction. Regarding timing, wounds should be well healed and tissue should be supple. Obviously, there should be no contracture of the CM joint or the first web space, and tendons cannot move contractures. And that seems to be something that's too often violated, which I could never understand. I never could understand why people do tendon transfers in cases where there's stiffness. It just doesn't work. For a mild adduction contracture, therapy is often effective, as in this 8-week-old gunshot wound in a police detective who had an irreparable injury to the motor branch of his median nerve. And the use of C-splints that are made progressively wider does achieve greater abduction. And a caveat about using these splints is that it's very important that the abduction force is against the metacarpal head or against the joint area and not against the proximal phalanx, because that can result in ulnar instability. And that can also result in ulnar instability in the use of dynamic or static progressive abduction splints, where the force is against the phalanx and not against the metacarpal head. If there's a mild contracture with little scarring, a Z-plasty of the skin is often effective. And it's important that the limb of the Z in the palm should be in the thenar crease. In more severe contractures, dorsal rotation flaps are often effective. And it's very important at surgery that the contracture is released to the axis of the CM joint, both in the palm and on the dorsum of the hand. So the contracture must go into the joint itself. The rotation flap is from the dorsum of the hand, and it extends over the proximal segment of the index finger. It's important to maintain a reasonable width of the base of the flap, and the donor site is covered with a split thickness skin graft. While it's important to release the contracture to the axis of the CM joint, the rotation flap need not reach that point in the palm. It does not have to go all the way that proximal, as shown here. Now talking about the selection of the donor muscle. Regarding force, we have to remember that opposition is really a preparatory position for both precision and power grip. Any muscle capable of moving a passively mobile thumb has sufficient force to be an effective opposition transfer. That muscle primarily provides movement, not grip force. The force in precision grip is provided mainly by the extrinsic flexor pollicis longus, and the force in power grip is primarily provided by the intrinsic adductor pollicis and to a slight extent, the extrinsic extensor pollicis longus. As we know, the EPL extends the thumb, but it also adducts the thumb. Regarding amplitude, it just has to be sufficient to position the thumb in opposition. It's much more important than force when selecting a donor. The 3.5, 5, and 7 rule of effective amplitudes is something that every hand surgeon knows about, where the wrist flexors and wrist extensors are 3.5 cm, the digital extensors and the thumb flexor is 5 cm, and the finger flexors, both the profundi and the superficialis, are each 7 cm. I mentioned before that the CM joint of the thumb is the most important joint for opposition, and the abductor pollicis brevis is the most important muscle. It's important more for the direction of its force, which is toward the pisiform, than the actual force of the muscle itself. The opponent's pollicis, which is the least important muscle for opposition, since it inserts only on the first metacarpal and does not cross the MP joint. So therefore, referring to an operation that restores opposition as an opponent's plasty is very inaccurate. Let me discuss some opposition tendon transfers, and except for one, I'll do it in chronological order. I saved the Bunnell one for last because that's generally the go-to operation for an opposition transfer. In 1922, Huber and Nicolaisen independently decided about using the abducted digiti quinti. It's interesting that two surgeons independently in the same year came up with the same idea. In 1929, Kamitz wrote about using the palmaris longus, and in 1947, Phelan and Miller, the extensor carpi ulnaris. And then later I'll talk about the Bunnell transfer of using the superficialis of the ring finger. In 1924, Bunnell wrote about using and making a pulley near the pisiform. And in 1938, he wrote about inserting the tendon not on the radial side of the thumb, but on its dorsal ulnar side. So first about the abducted digiti quinti. The primary indication for this operation has usually been the congenital absence of the thenar muscles. It's also applicable for post-traumatic cases, especially when there's a lot of scarring at the wrist that can interfere with tendon gliding. When making the incision, and it's an extensive incision in the palm, it's important that incisions are not placed on contact areas. So therefore, the incision is made along the radial border of the hypothenar eminence rather than on the eminence itself. Through this long incision, the entire length of the ADQ is exposed, and it's separated from the underlying flexor digiti quinti in a distal to proximal direction. The origin of the muscle from the pisiform is detached, but not from the FCU, because you have to protect the neurovascular bundle. And when passing the muscle subcutaneously, it's rotated 180 degrees. And the transfer is usually into the tendon of the abductor pollicis brevis. And you'll notice in this slide that the APB is very pale since it's been denervated. And you can get a very good result. The Kamitz operation was using the palmaris longus prolonged with a pretendinous band of palmar fascia. It's sometimes been used in conjunction with a decompression of the carpal tunnel, where the patient also has thenar wasting, as in this 75-year-old female. The problem with the operation is that it functions more as an abductoplasty, which is a term that Joe and Brigley used, rather than an opposition transfer, because you don't get very much pronation of the thumb. If possible, the palmaris longus and the pretendinous band should be routed around the FCU for better pronation. So this transfer requires, number one, that the patient has to have a palmaris longus, which is absent in about 10 or 15% of patients, and preferably, number two, that the pretendinous band is of sufficient length to route around the FCU, and that's not very common. Now, here's an example of a great result following a Kamitz procedure, and it's a great result only because the pretendinous band was sufficient length that you could wrap it around the FCU, and you can determine that at surgery. If it's not of sufficient length, a superficialis motor is more effective, which you can also perform in conjunction with the carpal tunnel decompression, or you could do it as a later operation. The Phelan-Miller operation is an uncommon operation using the ECU as a motor. This is a patient who had a spaghetti wrist, had a repair of all the flexor tendons, not the superficialis tendons. They were not repaired. And he also had repair of both median and ulnar nerves. He got back good sensibility in the median and ulnar nerve distributions, but he had no return of thumb or finger intrinsics. The only muscles he had available for transfer were the 3 wrist extensors. And when using 1 or 2 wrist extensors for tendon transfers, it's important that the wrist remain balanced postoperatively and is not radially deviated or ulnarly deviated. Therefore, if using only 1 wrist extensor as a transfer, use the middle one, the ECRB, because it's balanced by the ECRL on the radial side and the ECU ulnarly. And if you're transferring 2 wrist extensors, then use the ECRL and ECU and retained the one in the middle that inserts on the third metacarpal, the ECRB. So in this patient, the ECRL was prolonged with a four-tailed plantaris graft described by Brand for the finger intrinsics, and the ECU was used for thumb opposition, where it's transferred into the extensor pollicis brevis. And the way that's done is that the EPB is cut at its musculotendinous junction in the forearm. The insertion site is not disturbed, although fascial connections between the EPB and EPL are sectioned over the MP joint. And then that tendon is routed across the palm and is sutured into the ECU on the ulnar side. And it's unnecessary to make a pulley because it pulls in the right direction. There are a few other things that's important in this operation, and one is that the patient have a good functioning FCU, because if he doesn't, then postoperatively you're going to get ulnar deviation of the wrist. And this is him after he had the Phelan-Miller transfer. My go-to procedure for most opposition transfers is the Bunnell using the superficialis of the ring finger. It's okay also to use the superficialis of the middle finger. And when doing this operation, it goes around the FCU and then through a pulley. A word about harvesting the superficialis. It's generally done through an incision in the MP crease. A window is made in the tendon sheath between A1 and A2 pulleys. Both slips of the superficialis are cut, including the decussation. If you don't cut the decussation, then you can't pull the tendon out proximally. And you want to leave a stump of about 1.5 centimeters of the superficialis, because that will generally prevent PIP hyperextension postoperatively in those individuals who have normal joint laxity. So the superficialis is withdrawn through an incision in the palm, and it's often necessary to also make an incision, withdrawn through incision in the wrist, and very often you have to make an incision in the palm as well. A pulley is made using half of the FCU, and the superficialis tendon is first passed around the intact portion of this FCU, which ensures that the direction of the transfer is toward the ulnar side of the wrist, and then it's put through the pulley to ensure that the direction of transfer is toward the pisiform. This was a diagram that has been repeatedly shown, and I think the artist inadvertently drew what emphasizes my point, that when the superficialis is not passed around the FCU, but just simply passed through the pulley, what happens is that pulley stretches toward the midline, and rather than the direction of the transfer to go toward the pisiform, it's pulled toward the midline. Now you could say, well, if you put the superficialis around the FCU, why do you need a pulley? And again, the reason is you want that pull to come close as possible to the pisiform. And if you just put it around the FCU, that transfer could slide proximally. Usually the superficialis is inserted into the abductor pollicis brevis. My preference is I prefer to pass it under the EPL and transfer it into the ulnar side of the proximal phalanx, because you get better pronation by doing that. The first time I did this, I thought it was pretty clever until I read that Sterling Bunnell wrote about it in 1938. And this is his patient preoperatively and postoperatively. And you can see how good the pronation of his thumb is by where that transfer is attached to. And finally, I'll end with something that I entitled, Nothing is Written in Stone. And I always tell our fellows, and I'm sure Dr. Strauch and Lee tell their fellows the same thing, that once they graduate, anything they do is correct, provided they have a good explanation and they know the anatomy. So here was an example of someone who had thenar paralysis, and his FCU, he did not have an FCU, so you couldn't make it available for making a pulley. So why not do the same operation of using a flexus superficialis, but instead of putting around the FCU, I put it around the ECU and kept it intact, and transferred this tendon across the palm and inserted it into the ulnar side of the base of the proximal phalanx. and he had a pretty good result. Thank you very much.
Thank you, Dr. Posner. That was an awesome talk. Our last speaker is Monica Sue. She is a senior occupational therapist and certified hand therapist here at NYU, and she's going to be discussing rehabilitation after nerve injury and repair.
Thank you, Dr. Totola, for having us here. I'm going to be talking about rehabilitation after nerve repair. So let's get started. Okay. Our objectives for today is to describe the rehabilitation process after peripheral nerve injury or repair, and discuss the purposes of various orthoses used for post-peripheral nerve injury, and describe the strategies used for sensory reintegration or reeducation. Okay, in order to achieve our goals, our evaluation consists of assessing the patient's range of motion, edema, sensation, and, if appropriate, strength. There are several methods to assess sensation. Early in rehabilitation, Sims-Weinstein and two-point discrimination is frequently used. In the later stages, as a patient's sensation is improving, we may utilize a Moberg pickup test or a shape texture identification test as part of sensory reeducation. And the Moberg pickup test was modified by Dellon, and it involves identifying everyday objects without the use of vision, and shape texture identification test requires the patient to identify 3 shapes and textures in various sizes with their eyes closed. Patients with nerve injuries are also taught to visually protect their hands from noxious stimuli as they recover. They are instructed to inspect their skin daily for wounds and skin breakdown, especially if they are using an orthosis. And rehabilitation after nerve repair often begins with a period of immobilization to protect the repair sites. And during the period of immobilization varies with the different types of nerve repairs and the presence of concomitant injuries and other patient factors. Enhancing mobility of the joints proximally and distally can be performed during and after this period of immobilization. Edema and scar management are also key in early rehabilitation, and motor nerve injuries as the nerve recovers, strengthening of the affected muscles is incorporated. In addition to protecting the repair site, splints are also utilized to prevent and correct deformities that may develop because of motor weakness. Splinting is also used to isolate weak muscles and limit compensatory movements. In median nerve injuries, a C-bar orthosis, as seen in the picture on the left, may be used to prevent adduction contractures of the first web space. It is generally worn at night and positions the thumb in abduction and pronation. And the picture on the right is an example of a dynamic abduction orthosis that is used during the daytime, and it assists with functional grasp and opposition by positioning the thumb in flexion, abduction, and pronation, as Dr. Posner discussed. And this is an example of a low-profile dynamic finger extension splint that is used for patients recovering from radial nerve injuries or palsies. It supports the wrist while assists with extension of the MP joints to allow for functional grasps. There are other variations of this orthosis, including a higher profile one. However, patients may be self-conscious and don't want to bring attention to their hand, and therefore may not be compliant with their use. A lower profile version would be more discreet. This patient has a low ulnar nerve injury and was developing clawing of his ring and small fingers, making it difficult to open his hand for grasp. An anti-claw splint or lumbrical bar places the MP joints in flexion, thus allowing the IP joint extension without limiting composite flexion. And we don't always need to use or custom make orthoses. We sometimes would use prefab orthoses, such as the one that you see here. These are the ovalates that we use to minimize PIP flexion of the fingers and IPs of the thumb to work on isolating the weak intrinsic muscles that allow for abduction and adduction of the fingers and thumb. Based on the work by Dellon et al., the order of sensory return starts with pain, followed by stimulus that has a frequency of 30 cycles per second, moving touch, constant touch, and finally stimulus that has a frequency of 256 cycles per second. He cautions that sensory re-education should not start too early because patients may get frustrated and was usually started when patients are able to perceive moving touch. According to Dellin and Jabley, this may be around 4 to 6 months after median and ulnar nerve repair at the level of the wrist. As mentioned earlier, a sensation assessment is performed to determine the amount of sensory loss or return. Waylett Randall recommended that sensory testing should not be performed if the patient is hypersensitive because it may affect the response. For example, if they are hypersensitive, a 2-point discrimination may be perceived as pain, or localization may not be possible if they perceive touch as irritating. Sensory re-education starts with desensitization, and patients tend to have better outcomes if hypersensitivity is addressed early on in the rehabilitation. Desensitization can also include vibration, tapping, and massage, and gradually increasing the intensity. And touching different textures from softer textures and gradually progressing to rougher textures can be used. And we also want to encourage the patients to use their hands for normal functional activities. They may help stimulate sensation. In the later stages, localization and identifying objects should be used. And the brain plays a big part in the rehabilitation. After peripheral nerve injuries, the homunculus represents how the upper extremity takes up a large portion of the brain. After an injury, the area of the brain that is presented by the injured body part, in our case, the hand, is reorganized. This reorganization may be maladaptive and lead to phantom limb pain in cases of amputation, or in cases of peripheral nerve injuries, it can lead to increased pain, cold intolerance, or poor or dysfunctional motor movement. Strategies that can be used to reorganize the brain better include encouraging the patient to use their hand with normal activity, which helps reestablish the cortical connection using meaningful sensory and motor experiences. And it also stimulates real-life activities instead of just tactile stimulation. Secondly, limiting sensory input of the unaffected hand can also be a strategy that some use. Theoretically, the adjacent intact area's own representation within the cortical map is limited, and the spread to the areas represented by the injured areas is minimized. Cross-sensory substitution also involves using technology to convert tactile information to other sensory information, such as sound or visual stimulation. Mirror therapy is a way of stimulating the area of the brain that does not have a clear representation of the affected body part and helps the nerves regenerate in more organized and functional manner. This is an example of a cross-modal sensory substitution. When performing mirror therapy, the patient's affected hand is hidden behind a mirror. Their focus is on the hand that is reflected in the mirror, which is supposed to be a representation of their affected hand. A stimulus, whether it be a texture or touch stimulus, is then applied to the uninvolved side. The brain is confused with what they are seeing and with what they are feeling, so eventually it needs to make sense of the two, and eventually the brain will see and feel the image in the mirror is really their affected hand. In the later stages of sensory re-education, we work on the patient's ability to identify textures, objects with their eyes closed. First, the patient is asked to pick up an object with their eyes open, then close and open again. The patient is able to identify objects in this manner successfully, and this takes a lot of practice. And finally, when muscle reinnervation is noted, we can also use biofeedback or neuromuscular electrical stimulation for strengthening. Superficial electrodes are placed on the muscle belly of the muscles that you are trying to engage, and a biofeedback machine will pick up the signal if the active muscle contracture is strong enough and provides a visual or auditory feedback to help the patient learn to isolate the muscle that they are working on. And an NMES, on the other hand, uses an electrical stimulation to trigger a muscle contraction to help strengthen the muscles. Okay. And one of the things that Dr. Azad had alluded earlier on, it was patient expectations. And it's important to talk about patient expectations early on. So because sometimes sensory recovery takes a long time. Thank you.
Awesome. Thank you, Monica. Okay, we have a couple questions from our audience, and we can open these up to all of our speakers. The first one is a 53-year-old who had a failed carpal tunnel release, has a revision with injury to the motor branch. 1 year later, allograft repair also fails. Any recommendations?
Depends on what the functional impairment is, if any, of the thenar muscles. Because in a third of the patients, the radial head of the flexor pollicis brevis is innervated by the ulnar nerve, and sometimes patients have sufficient abduction that they don't need an opposition transfer. However, if there's a severe disability, I would do an opposition transfer.
I agree.
I would
It's too
agree
late to
with Dr.
do.
Posner too.
Yeah, it's too late to do any nerve work. So if they really have a functional deficit, then opposition transfer. My preference is, sorry, Dr. Posner, is actually the EIP to ABB. I don't want to go into other fingers. It's worked well for me. You have a nice pulley, that's the wrist. And a couple things when I do it, though, is I make sure that you want to make sure that you harvest all the way to the end because it barely reaches. And I do splint in that position in a non-removable, like plaster type one, for 4 weeks because I don't want it to pull out of there. And when I come around to the ABB, I will make sure I do a pulver tap, go through the tendon and back to itself. So just some kind of thoughts about that.
After you splint them for 4 weeks, and then do you just let them go, or do you let them?
Oh, no. A non-removable one for 4 weeks, like a plaster one. So 2 weeks plaster in the OR, then I come back in 2 weeks and I put a new one on, but I do it myself in the office, in palmar abduction, and then they go to a thermoplastic. No, yeah. So that thermoplastic for another month, and they gently start moving, but they're still protected for solid 8
for a while.
If not,
Gotcha.
if not 10.
Okay. Dr. Posner, how long do you protect your FDS opposition tendon transfers for? I think you're muted.
Until the bill is paid. Therefore, I don't have to remember all of these numbers of 6 weeks, 4 weeks, 8 weeks. It's too confusing. So if I just have one variable of, whether the bill is paid or not, that makes it much easier. No, seriously, at 3 to 4 weeks, I'll start them exercising, but they wear the splint for a total of about 4 to 5 weeks.
Okay.
I was going to ask Dr. Lee a question that he doesn't like to go into another finger. Has he ever seen a disability of harvesting a superficialis tendon from a finger?
I'm trying to unmute. Yes, I have. Particularly if somebody is it's kind of lax, and they're kind of a person who's going to be, swan necker type person. Is that a word? Swan necker?
Probably not.
Yeah, probably not. So, and I've seen, I guess it's not like a ton of people, and I don't do it that often, but I just don't, I've had people complain about their fingers, and I have seen, remember particularly as one other patient, he's a guitar player, and he's like, oh, now it doesn't feel the same, stuff like that. So, if I can just avoid that, and right, it's not like I have a ton of people I compare it to, but I just find that, it works for me. And I think it's another option to think of.
Now, one thing I'll mention, if you're using a superficialis, since the ring finger is not splinted postoperatively, it's important the following day to make sure the patient extends the finger completely. Because if you leave a stump of the superficialis, it can get scarred down and it can cause a flexion contracture. So if they don't fully extend their finger, I'll passively extend it for them. So.
Dr. Lee, in your experience, have you ever had patients post-operatively for a short period of time have a slight extensor lag with those transfers? Although they have the other tendon, some of my partners anecdotally have said, make sure you counsel these patients that they may have an extensor lag for several weeks. I don't know if that's been your experience.
I haven't seen that. I take the stump of that EIP and I sew it to the the active motor, so distally I do suture there. Thankfully, I haven't seen that. It's not like I have a gazillion of these, but I when I came here, that was being used more, and at Athanasian likes it a lot. And just talking to people, they say that they haven't had trouble and it works well.
We do a fair amount of EIP to EPL transfers, much more than opponents' plasties for that. I've never seen an extensor lag of the index finger from that.
No, and it's never, from what I've gathered, it's not permanent. I don't know if it has to do with swelling, surgical site pain, or what, but
yeah, that's a great point, Rob. That's a much more common thing to do is the EIP to EPL. Thankfully,
and the other thing is
that's a nice tendon transfer. It works well.
You don't lose the ability to do this when you take the EIP, surprisingly.
Very important to be able to do
that. Okay, and there was a second question. This might probably be directed more to Dr. Lee and probably Dr. Zad. Is there any current evidence regarding using the use of electrical stimulation to promote axon regeneration in the peripheral nervous system? I think they might be referring to like using a checkpoint intraop to stimulate the nerve.
They might be referring to Tessa Gordon's work, Canada. It's there's thoughts of using that. It's not widely used or anything. I think that could be something that would be in the future, something you could implant, and doing it for a short period of time. It's a longer period, so potentially that's an area of innovation to have something that's implantable and then you pull out a lead or something. Good question. I mean, there's a lot of possibilities. Peg fusion is very interesting. Using other growth factors, and there's a ton of research. It's not just a commonplace thing to do. I think one of the big things that's not going that far is really just being better technically. Dr. Azad talked about not over tightening it. Doing nerve surgery is so different from vascular surgery. Like a vessel, you want watertight, literally. And the nerve you want like super loose. I mean, you'd rather have it not touching than like doing this. Like he had that one photo, but there's this saying like, it's like kissing your grandmother, not like, what. So you don't want to be like just barely there, sliver of light between, loose. I mean, you have these air sutures. It looks weird at first, like air knots. And I tell my trainees, like those sutures are just like seat belts. You just want the nerve not to do this. So that's why I just put two just to line it up. I do very minimal sutures just to line it up. And then do glue. I also mentioned sometimes the conduit on there. You might have seen like connector assist. And also I learned from when I was visiting both Oberlin and Bertelli, and they kind of said what Dr. Strauch had said, like, when you say no tension, that doesn't exist, because if you cut somebody's median nerve like right away and you repaired it right away, I mean, there is some tension there because there's elastin in the nerve. And so it's not zero. Like if you read something like it's zero tension, that doesn't exist. It's not zero. It's just like you try to control it. And other ways you can control it. Like I learned from Bertelli, he was putting mesh behind median nerves, and he was putting a nerve like one end here and one end here on vicryl mesh, and then putting detensioning sutures away from their parasite. Like kind of like, Dr. Azad showed, detensioning sutures. And that's a way to control the tension so that it's not all at the repair site, and then minimal sutures at the repair site. So I think a lot of the advances aren't just with, fancy electrical stim and other things like that. It's actually just technically being better. I would have to say, though, I do take issue with what you said about loops and microscope. I really think I'm better under a scope. I mean, I can see way better detail. For me at least, I don't think I'm as good under loops as I would be under a scope. Not only seeing how far back to cut, but just accurately putting in those sutures, because you don't want to, like, those sutures going through the epineurin should be see-through. like you see your suture through there, that's the right one. And if you don't do that, you're going through fascicles, and I can't do that in loose. I mean, I don't know, maybe other people can, but I can't do that.
No, I agree. I much prefer the microscope. I think technically you're right. I think, at the end of the day, the surgeon is the technique. I think we need to focus more on the techniques we have and improving upon those techniques. And then as far as electrical stim, I agree. I think some of there's not any human studies or trials or data, but I think some of the future may be for either an implantable electrical stimulator or short periods of like 2 milliamps of using the checkpoint in cases of really severe, for example, ulnar nerve atrophy or brachial plexus cases where you do a decompression and then you kind of want to instigate the nerve a little bit, but that all needs to be borne out. Right now, it's not clear one way or another if that's beneficial.
Has anybody tried the Steve, you mentioned PEG fusion, which is polyethylene glycol, which is also almost a magical thing. You have to get to the nerve when it's cut within, like a day, and you put the PEG stuff on it, and it does not undergo Wallerian degeneration in animals. And I think there are a few very promising results in humans, maybe 1 or 2 case reports as far as I know. But has anybody tried that? Of course, you have to get them to the OR immediately, which is not usually something that we encounter very often with nerve injuries.
Yeah, I haven't. I mean, I think the best case scenario would be if you called in by your colleague who accidentally in surgery cut one, and you just go right in there. Or, you get called in with one of those lacerations from a knife injury or something like that. Those would be great ones for it. I haven't done it yet. It's very intriguing, and I've heard, some information that makes me really, want to have a scenario like that. I think it would be great to just make sure you have it around, and if you get called in for that, to at least try that. I would probably put a couple of like just seatbelt sutures in, and but yeah.
I would think that they could try that on hand transplants, which are elective cases, right? They just peg them together to cut the nerve, put it back together again with another nerve, and maybe it would work immediately.
Yeah. I mean, absolutely. You could try it in that kind of scenario. There are definitely defined scenarios. Yeah, unfortunately, you don't get them usually in a day. Even like in the best scenario, you get, it's a couple days out. You're happy if you get it in under a week. I am, at least.
And then I have one question of my own. How do you approach partial digital nerve injuries that don't have a large gap, and also partial mixed sensory motor nerve injuries?
Yeah, and you're talking more chronic probably, because if it's that fresh, you can just kind of
right.
Maybe put one stitch in or put a wrap around it or something. Those are so tough. I hate those. Because there's a person who has partial function. Usually pain is their main complaint. I had this terrible one who had sciatic nerve partial injury, and it's just like, she has 4 out of 5 power distally, but terrible pain there. I find it very hard. I mean, I've tried to go in and sometimes under a scope take out a couple, like a partial neuroma continuity, maybe graft, or just take out part of it, put a wrap around it. It's been variable what kind of results I get. And the other problem is when it's pain, they often have central, like an affrontation type situation and partial CRPS, and it's really tough. I tell patients when they have a CRPS type picture that it's gotten to a point, I kind of liken it to like phantom limb pain or like a bad memory that you can't get rid of, and your brain has a memory to pain that you can't eradicate no matter what it is. So I think, you can try to do some stuff, but it's really, I really have a long discussion with what kind of result they can get.
Yeah, absolutely. I think I spend the most time with those patients just talking to them about, what their deficits currently are, how much it bothers them, if a surgery is worth it to them, and they have to come to the realization that given how much scarring is at that partial nerve site, there's a real possibility that, they could be left with a little bit more dysfunction than they had going in. Because sometimes the clarity of the nerve fascicles, even under a microscope and a beaver blade, and being meticulous isn't all that clear. So it's just they just really have to be counseled before they approach that.
One thing that Rob you didn't talk about, and I wanted to just say about the allograft that I use it more. The most common thing I use it for is actually for a painful neuroma. I mean, not a partial, but like a real complete or a neuroma in continuity, but it's actually like damaged. Frequently with trauma or surgery, those I use the allograft for, and they've been not always successful. Nothing ever is in nerves, but it's been around 75-80% that it seems like it's really helped people. I don't want to take an autograft for somebody who already has a painful nerve, and if if it's too long, that I really feel like a hollow type situation is usually a kind of a shorter gap, like a centimeter or less. That probably would work. So in those kind of scenarios, I think that an allograft could be used. I've also used the translocation method, where if you just have a really short stump and you can't make it long enough to bury into like somewhere deep, like a muscle, and it's somewhere that's very sensitive, like a bottom of a foot or something, I'll lengthen that with the allograft and then bury that deep. That's been published by a couple investigators from Chicago and St. Louis and stuff. So I have a kind of small series that I'm kind of working on too. So it's I think it has its place. It's not for everything. I don't use it. I agree with you, Dr. Stretch. I don't use it for like a major mixed motor. For that one, I will do a central nerve graft, like a median nerve gap or an ulnar nerve gap, like a real one. I prefer to use Autograft.
Painful neuromas are really difficult problems. I agree. Particularly, if it's partial, I'll resect the partial neuroma. But if people have tenderness in the nerve going proximally, it's a bad prognostic sign. But sometimes I try that they use desensitization techniques. And one thing that helps is if the patient actually massages the area. And I find if they say, and they have to say out loud, it sounds peculiar, that it doesn't hurt, it doesn't hurt. And I always advise that they do that in privacy, because if they keep saying it out loud, their family will think they're crazy. But I think in some patients, desensitization with their own technique really works, but they have to do it frequently. But it's not a good problem. Not a good.
And
go ahead, JD.
no, it's okay. You can go ahead.
I was just going to mention that some people use the hollow nerve conduits, a long conduit, and plug it into the end of a neuroma, cut the neuroma, plug it in, and let it peter out. And there has been some success with that technique as well.
Yeah, kind of like a nerve cap. Yeah, we didn't talk about those. I mean, Action has a nerve cap too, which is kind of like that. It's a hollow situation. And so, yeah, it's they're tough. I mean, I think there is a population of patients who have painful neuromas, though, that can be helped surgically, and they're just in pain clinics, given a lot of pain meds and stuff like that. And that's an underserved group that I found. And I've treated, like not everybody is like an awesome result, but a lot of them have been helped, and it gets some better treatment than being on meds or, I've even had people who have just like a finger amputation, a terrible end stump neuroma, can't use their hand, and no one's told them that it's a neuroma. I mean, it's amazing. And if I suspect it, an injection, anesthetic injection with Marcaine, I'd prefer Marcaine because it lasts longer and they can actually test it. Lidocaine's too short, but if they say that really helps that pain, that's a really good sign that a surgery could help them, I think.
And Dr. Azad or Ali mentioned that some people will actually send the cut ends of the nerve proximally distally to path. Do any of you do that as part of your intraoperative kind of assessment of the nerve quality before you do your repair?
When I was with Guy Povataft, he did that all the time. And I really was very impressed with it. I've never seen anyone else ever do that. And as others have pointed out, you really need a pathologist on site. You need a pathologist tuned into it. But he would get an answer within 15 minutes at most. And every time he did it, he would always ask me, what percentage do you think is scar tissue? And there were several times that both of us were really wrong, that the pathologist said 60% scar tissue, and he knew to cut more. And I think it's really a wonderful technique, but I've never seen anyone do it. And as you pointed out, it's really, to do the procedure in most hospitals, it's really not doable.
We do it for our plexuses for the nerve roots. I don't do it for other things, but nerve roots we do it, and it takes not 15 minutes. It's probably maybe 20 to 30 or something. We have that. I mentioned that publication we did about the long. It's called long nerve grafts. We compared long nerve grafts versus the triceps radial to axillary nerve. Transfer, and they were equivalent basically. And in that, we describe how we do it. We send it to the pathologist. We want at least 75% preserved neural tissue. So they'll give us two numbers. They'll say how much of the nerve is actually neural tissue, because there's a lot of connective tissue that's around there. And then out of the neural tissue, how much is actually preserved. So we want at least 75% of the neural tissue to be preserved. That was just arbitrarily selected, though. We don't know. We actually don't know like what you need. But in that paper, by using that criteria, these long nerve grafts, and I mentioned, because that's really like from here all the way down to like here. That's really long. I mean, they can be, I remember them being as long as something like 15 to 17, like really long on the long end. I mean, a short one would be at 11, so that's not even that short. And amazingly, I mean, not all of them work, but a lot of them do. I did visit Halam Malassi. I did nerve travels, and I did a sabbatical in 2011 and 12, and I did visit him. And it was really amazing to hear him tell the stories back in the day when they battled about nerve grafts versus what they did is they would shorten they would do an osteotomy. Maybe Dr. Posner would remember those times when they would shorten the extremity to bring the nerves together instead of grafting. He said that it was epic battles between him and other surgeons at the time. And so he just said the grafts work. It's just that you have to do it. You have to do it correctly, and you can't do it too late. And he said, like, if they're done incorrectly or they're done too late or the wrong indication, they've got a bad name that they didn't work. And I remember him telling me that, and I came back to New York and we did them, and I saw with my own eyes that they actually can work in some scenarios.
I think that is the end of the questions from the audience and myself. If there are no questions, then I want to thank all of our speakers, Ali Azad, Robert Strouch, Steve Lee, Martin Posner, and Martin Sue for their outstanding presentations. I think we learned a lot about the management of nerve injuries, and we'll be able to take away a bunch of pointers to incorporate into our strategy in terms of treating, incorporate this stuff into our clinical practice. And of course, I want to thank our audience for tuning in tonight.
Good job, JD.
Thanks, JD.
Listener. Thanks, guys.
All right. Okay. See y'all later. Take care. Have a great night.